population screening, for example, newborn screening, may hold the prospect of uniform detection, but that's a complicated process. Well, as you point out, we did study a large number of individuals who were using direct-to-consumer testing, and many of those individuals did discover that they had alpha-1 antitrypsin deficiency. Every patient with chronic obstructive pulmonary disease with fixed airflow obstruction on pulmonary function tests, even if the clinician labels this as asthma, as long as the airflow obstruction fails to completely reverse with bronchodilators, every such individual should be tested, in my view, with a serum level for alpha-1, a simple blood test, and a genotype for alpha-1 antitrypsin deficiency, also a simple blood test.
Welcome back to part 2 with Dr. James Stoller, where we explore further Alpha-1 antitrypsin deficiency. Let's dive in. Okay, and I guess you've published extensively on the detection and diagnosis of Alpha-1. In your opinion, what are the biggest current barriers to timely diagnosis?
Well, there are several. I think there's a general lack of a gap in understanding of Alpha-1. That's why I appreciate the opportunity to engage with you and your listeners here. Number one, there is a sense of therapeutic nihilism among physicians, even those who understand Alpha-1, the idea that there is no effective therapy. And if that were true, why shackle the patient with a genetic diagnosis? Now, the premise there is false. There is effective therapy, and there are therapies in the pipeline that are quite promising, as I suggested. So the notion of therapeutic nihilism is unjustified. Those are big reasons for under-recognition. Primarily, a lack of understanding and knowledge gap.
So one of your recent studies looked at electronic health record-based strategies to enhance the detection of Alpha-1. Can you explain how technology is changing the diagnostic landscape?
Yes, me and others are very much trying to capitalize on new technologies to aid physicians. And there have been a number of approaches, all of which have demonstrated small increments in testing, but none of which have completely solved the problem, if you will. Some of those approaches have included issuing prompts in the electronic medical record whenever a patient has, for example, a guideline indication for testing, including fixed obstruction on pulmonary function tests, cirrhosis, etc. And so in such circumstances, we've studied in others that when pulling up the electronic medical record for that patient, a big flashing alert with an opportunity to one click on the electronic medical record and order a serum level for alpha-1 antitrypsin and a serum genotype. Other strategies have included, and we're currently involved in research, still preliminary, looking at AI running within the electronic medical record to help identify patients at high risk of having alpha-1 and prompting the physician to again test. We've also looked at other strategies with the EMR, electronic medical record, in which, taking advantage of a patient portal, we use a system called Epic. Epic has something called MyChart, which is a patient-facing portal. And in a study that we did several years ago, when patients were prescribed a medication for chronic obstructive pulmonary disease, particularly an antimuscarinic and a long-acting beta agonist, for which the indications are uniquely for COPD, such patients were issued a prompt in MyChart suggesting that they be tested for alpha-1. And that strategy, like all the others, have certainly detected some individuals with alpha-1 antitrypsin deficiency. The challenge is to identify all individuals with alpha-1, and we've not achieved that goal to date.
Do you think you're close to that?
I hope so. I wish I could tell you that we were there. My description of stubbornly persistent under-recognition earlier defines the fact that we've not completely solved the issue. Population screening, for example, newborn screening, may hold the prospect of uniform detection, but that's a complicated process and has not been fully endorsed, at least in the United States, although there have been pilot studies of newborn screening for Alpha-1.
So another of your studies showed high levels of health engagement following direct-to-consumer genetic reports. How do you view the role of consumer genomics in Alpha-1 detection?
Well, as you point out, we did study a large number of individuals who were using direct-to-consumer testing, and many of those individuals did discover that they had Alpha-1 antitrypsin deficiency. And we demonstrated that the detection of Alpha-1 through home testing or direct-to-consumer testing did result in changes of habits, at least self-reported changes in habits in these individuals. A lowering of the rate of cigarette smoking, which is, of course, highly advisable in Alpha-1. Smoking cessation is critical. Some curtailment of alcohol consumption, given the liver risk. These were all self-reported behaviors that resulted in individuals who found themselves to have Alpha-1 in direct-to-consumer tests.
Now, I think I know the answer to my next question because we have discussed it. So, do you think universal screening for Alpha-1 amongst COPD patients should be standard?
I do. We would actually call this targeted detection as opposed to screening. Screening being testing in individuals who have no predisposition. But in individuals with COPD, they have a strong indication to be tested, and that would satisfy criteria for what we call targeted detection. That said, to your point, quite excellent, every patient with chronic obstructive pulmonary disease with fixed airflow obstruction on pulmonary function tests, even if the clinician labels this as asthma, as long as the airflow obstruction fails to completely reverse with bronchodilators, every such individual should be tested, in my view, with a serum level for Alpha-1, a simple blood test, and a genotype for Alpha-1 antitrypsin deficiency, also a simple blood test.
And that's a wrap on part 2. Thanks for listening.